necrosis in osteomyelitis. In case of mandible, it may be osteoradionecrosis. It may be medicine-related osteonecrosis observed or due to any reason, or it may be comminution fracture if the fracture is comminuted, or it may be defect fracture if the part of the bone is lost, then it is considered as the bone is of reduced quality, bone buttress is not sufficient. The simple thing is, in all these cases, when the bone buttress is not there, you have to just remember the word bone buttress or bone strength. If the bone strength is not sufficient, bone is of reduced quality, bone buttress is not there, then you have to go for reconstruction plate. You have to put a reconstruction plate. In such cases, you can't put a mini plate. Mini plate is only for if the bone is strong and if the bone buttress is sufficient, then you can put a mini plate. Otherwise, you have to put reconstruction plate. Hello? Hello? The patient has a OT son over Jaipur. No class leaders. What is another answer? So it's simple. Whenever you find the bone buttress is not sufficient, bone is weak, then you have to put a reconstruction plate. If the bone buttress is sufficient, then you have to put mini plate. Now, these are the example of atrophic mandible fracture. As you can see, there is fracture in the edentulous mandible, bilateral bodies fracture. It is very common fracture in edentulous patient because the bone is comparatively strong in the symphysis region and angle region. So the fracture usually takes place in the body region. There is bilateral body fracture, and it is also known as bucket handle fracture. Because due to contraction of anterior belly of digastric, geniohyoid and genioglossus muscle, the interior part of the mandible will go down like a handle of the bucket. That's why it is also known as bucket handle fracture. So in such cases, you must not put mini plate. Okay, you have to put a reconstruction plate. Another important thing is in these cases, reconstruction should be placed and it should be large enough so that the bilateral body fracture is connected with the same reconstruction plate. Another thing you have to consider is if you see the whole of reconstruction plate adjacent to the fracture, we haven't put any screw adjacent to the fracture because the bone which is present in the body region is very thin. So you can't put a screw bicortical screw in this area. You have to always put the bicortical screw where the bone buttress is sufficient, bone is strong. So in case of geriatric patient, old age patient, you have to put the screw one in the angle region or ramus region, another in the anterior symphysis region, because in most of the cases, resorption will not be there, or comparatively there is less resorption in the interior mandible as well as ramus or angle region due to attachment of muscles. Because the muscles is attached there, blood supply is sufficient, so less resorption takes place in this area. So you have to put the screw in the symphysis region as well as in the angle region, never adjacent to the fracture. Unlike other fracture, in case of young patient, you can put a screw just adjacent to the fracture line because the bone buttress is sufficient, bone is enough. But in case of geriatric patient, in old age patient, you have to be careful. So you have to put the screw in the angle region and symphysis region. Both the body fracture is connected with the same reconstruction plate. Okay, from one angle, left angle to the right angle, it's the same reconstruction plate. You have to bend the plate and you have to put a same plate on both sides. Another variation can be, in this case, you can put a reconstruction plate at the lower border of the mandible as well. It is present on the buccal surface, facial surface, near the lower border of mandible. Another variation can be you can put just at the lower border of the mandible. That is also indicated. Okay. In such cases, you have to approach from submandibular incision, extraoral approach. Because in case of edentulous mandible, if you give the incision from the transoral approach, intraoral approach, in case of, as you know, in case of edentulous ridge, you have to give the incision just above the residual alveolar ridge at the alveolar crease. But in these cases, in geriatric patient, if you give the incision over the residual alveolar ridge, you may damage the mental nerve, because what happens due to the resorption, the mental nerve is present in the body region of the mandible, right? In the region of usually at the second premolar area. But what happens in case of geriatric patient, the residual resorption. Sometimes what happens in most of the cases, mental nerve is just present above the residual ulnar ridge, at the crest of the ridge. So if you give the incision in the crest of the ridge, you may damage the mental nerve. So be careful. It's always better not to give the transoral incision in case of geriatric patient. Incision should be given extraorally from the submandibular incision. You have to extend the submandibular incision to the submental incision, and you have to connect both the submandibular incision with the submental incision. That is, the surgery should be done from extraoral approach in case of geriatric patients. Okay. If you give transoral incision or intraoral incision above the crest of the ulnar ridge, you may incise the mental nerve. So there will be permanent paresthesia in the mental nerve. The chances of recovery is very less in case of old age patient. As you can see in left side, both the body is fractured and it is fixed with the mini plate. The problem is, even though it is fixed with the mini plate, you can see the post-op case after a few months, both the plate is fractured. It is shown here just to show that if you place a mini plate in such cases, it will fracture. So you have to operate it again. Mini plate fixation of bilateral fracture in an atrophic mandible, failure of mini plate fixation, plate fracture on both sides. So never put mini plate in such cases. Another condition is multifragmentary mandibular fracture. Comminuted fracture of mandibular angle and ramus area is present. Primary adaptation of the fragments with mini plates and monocortical plate screw. Subsequent stabilization of the comminuted area with reconstruction plate 2.4 and bicortical screw placement. So another example is there may be comminuted fracture. Usually in case of road traffic accident, it is if it is severe road traffic accident, then the bone there may be comminuted fracture in mandible. Now be careful. We have placed. You have to put reconstruction plate. You don't have any option in case of comminuted fracture. Mini plate is placed only in case of if the bone buttress is sufficient in case of a strong bone. In such cases, in comminuted fracture, you have to put reconstruction plate. But you can see we have placed some mini plates as well. To be clear that this mini plate is not placed for fixation of fracture. Okay, it is placed just to assemble the small fragments. And this process is known as simplification. I think they have asked twice, what is simplification in case of comminuted fracture? Simplification means assembling of all the fracture fragments by using either 2 mm mini plate or 1.5 mm mini plate. The purpose of mini plate is not to fix the fracture area. Its purpose is just to assemble the small fragments. That's why we haven't used the long mini plates. Its purpose is just to assemble the small fracture fragments in case of comminuted fracture. Once all of them are assembled together, then the reconstruction plate is placed. While placing the reconstruction plate, be careful. At least 3 screws should be placed anterior to the fracture line as well as posterior to fracture line. On either side, there must be at least 3 screws. Okay. In case of comminuted fracture, there are multiple fragments. These fragments are assembled together with the help of mini plates, and this process is known as simplification. This mini plate is not used for the purpose of fixation. Its main aim is to just assemble the small fragments, and this process is known as simplification. After simplification, after all the fragments have been assembled together, it is now fixed with reconstruction plate. Reconstruction plate is always placed at the lower border of the mandible or posterior surface of the ramus, never in the superior region or in the body region. Because we have to place the bicortical screw. Bicortical screw should not be placed in the body region or the superior surface or in the superior surface. One reason is there is presence of tooth bone. Another reason is the more compact bone is present always at the lower border of the mandible. It has to hold both the cortex. Another example of comminuted fracture here, multifragmented fracture of on the left side of the mandibular body is present. The nerve remained still intact. Fracture stabilization with 2 mini plates as tension band, monocortical screw placement. and one reconstruction plate to bridge and stabilize the comminuted area. Tooth-bearing fragments should be aligned with the arch bar. Again, the comminuted fracture should be assembled together either with the help of mini plates or arch bar. After all the small fragments are assembled together, then the reconstruction plate is placed. Okay, you can see that free screw is placed posterior to the last fracture line. Okay, again anterior to the fracture line, 3 screws are placed. So be careful, at least 3 screws should be placed on either side of the fracture line, whether it is mini plate or reconstruction plate. But only in case of mandible. In maxilla, it's different. In case of mandible, you have to place at least 3 screws on either side of the fracture line. If it is continuity defect, then the scenario is different. Then you have to place at least 4 screws on either side. In case of defect fracture or in case of rejection, if there is, we can say it as a continuity defect. If there is continuity defect, if the bone is not present, you have to bridge with the reconstruction plate. Then in such cases, you have to place 4 screws on either side of the defect. If you are replacing the condyle, then in such cases, there should be 5 to 6 screws in the interior surface, because you can't put the screw posterior to the condyle or superior to the condyle. So you have to place put the screw only in the interior region. In case of condylar plate, you have to place 5 to 6 screws. Again, in this case, the small fracture fragments are assembled together with the mini plates, and this process is known as simplification. Again, comminuted fracture in the chin area with considerable dislocation of the various fragments, stabilization of the comminuted area with a reconstruction plate, and at least 3 screws in the non-fractured body area is placed. Superior small fragments are aligned through the arch bars. Sufficiently large fragments are fixed to the plates as well. Again, it is a comminuted fracture present anterior to the mental foramen, anterior mandible. In anterior mandible, there is comminuted symphysis and parasymphysis fracture. So again, you have to assemble the small fragments with the help of mini plate, and then you have to place the reconstruction plate. So the concept is at least all the fragments should be stabilized with some screw or some plate. In this case, as you can see, the superior fragments are holded with the arch bar. The inferior fragments are holded with the reconstruction plate. That's why we haven't put any mini plates in this location. Sometimes what we do, we place mini plate, we assemble the fragments. Okay, we place here mini plates. After placing the reconstruction plate, again we remove the mini plates intraoperatively. Okay. The purpose of mini plate is just to assemble the small fragments. Once the fragment is held together by the reconstruction plate, we can remove the mini plate intraoperatively. Defect mandibular fracture. Defect mandibular fracture, if some bone loss is there is continuity defect. And defect is usually present in case of treatment of pathology. If you are removing some amyloblastoma or if you are removing some tumor, in such cases you have to remove whole of the tumor area. In such cases, most of the time we create some defect. On such defect fracture also, we have to put reconstruction plate, and it is always better to put some graft. And for maxillofacial area, the best graft to use is anterior iliac crest, because you can take both the corticocancellous graft as well as cancellous graft from the anterior iliac crest area. Here, multifragmented defect fracture is present in the chin area. Capitular fracture on the left side. Primary adaptation of multifragment fracture zone by a mandibular maxillary fixation with arch bars. Stabilization of the fracture zone with a reconstruction plate fixed with 3 screws on either side of the comminuted area. One fragment tooth bearing is fixed with a mini plate. The defect area is filled with a bone graft. The condylar head fracture is treated non-surgically. So in this case, you can see there is comminuted fracture in the anterior mandible. The bone loss is there, so there is defect as well as there is condylar head fracture in the left side. Left condylar head is fractured. Now what will you do in this case? What is the treatment for condylar head fracture in case of adult patient? Condylar head fracture is treated by non-surgically close treatment. You can't put any plate or screw in the head area. Okay. For condylar head fracture, it is close treatment, non-surgical treatment. So for left condylar head fracture, you don't have to do anything. It is non-surgical treatment, close treatment. For anterior mandible, again, all the fragments has to be assembled together with the help of mini plate. Then you have to put a reconstruction plate, as there is bone defect as well. Bone is lost from the area. So in that area, you have to put bone graft. And most commonly, we take a bone graft from the anterior iliac crest. The next variant of type of fracture is infected mandibular fracture, and most commonly, the bone is fractured in case of osteomyelitis, in case of posterior necrosis, and those fractures are known as pathological fracture. It is due to pathology. And if there is infection, then again, you can't put a mini plate. In case of infection, the bone is weak, bone could not bear the occlusal force or functional forces. In such cases, you have to put a reconstruction plate. It is an acutely infected fracture of the mandibular angle, bridging of the infected area with a reconstruction plate. At least 3 screws are placed on either side and well away from the infected zone. Always you have to put the screw which is where there is healthy bone. You should never put any screw in the infected zone, because it will not hold the bone or mandible. So you have to put a screw away from the infected area in the healthy bone. At least 3 screws should be placed on either side, and the defect has to be filled with bone graft. Whether it is a case of osteomyelitis. And another thing you must remember in case of infection is, whenever there is infection, you have to remove all the infected area. You have to do curettage. If there is osteomyelitis, all the necrotic bone has to be removed. If it is osteoid necrosis, all the dead bone has to be removed. Don't leave the dead bone in that area. The problem is, if you leave the dead bone in that area, it will spread. Okay. It will devitalize the adjacent bone as well. So you have to do curettage. You have to remove all the necrotic bone in case of infection. Sometimes what happens, if you treat them as simple fracture, and if there is interfragment mobility, there is a seepage of oral fluid, it will lead to infection. In such cases, again, you have to operate. You have to repeat the surgery. In such cases also, you have to curate all the infected area, and then you have again you have to put the reconstruction plate. So remember that whenever there is infection, you have to remove all the pus, all the necrotic bone. Until and unless there is bleeding bone, you have to remove all the bone. The only clue intraoperatively whether to identify whether it's necrotic bone or a healthy bone is, you have to look for bleeding. If the bleeding is intact, if the blood supply is there, it indicates that the bone is vital. In case of posterior necrosis, in case of osteomyelitis, bleeding is not there. The bone is completely dry. The smell is also highly offensive. Pus will be present. So you have to curate the bone till fresh bleeding is there. And in case during the curettage, it's difficult to curate with hand instrument. You might have to use round bore, which you use in case of prosthodontics for trimming the acrylics. You have to use the round bore. You have to trim all the bone. You have to curate the bone. You can't easily remove the bone with the help of hand instruments. So you have to use the rotary instruments. You have to remove all the necrotic bone. After all the necrotic bone is removed, all the infection is removed, you have to irrigate the area. Once the fresh bleeding is present, once there is no more offensive smell is present, then you have to do copious irrigation, and then only proceed for fixation of the fracture fragments. Now, mandibular fracture is completed. We will head to the mid-face fracture. In mid-face fracture, we will talk about leaf 4-1 fracture, leaf 4-2 fracture, leaf 4-3 fracture, then ZMC fracture, zygomatic maxillary complex fracture. As the name itself suggests, it's complex, and its treatment is also complex. Because even there is a minor discrepancy of 2 mm, there will be facial asymmetry, so that you have to be cautious while treating the ZMC fracture. Then orbital rim fracture, naso-orbital ethmoid fracture, NOE fracture, nasal bone fracture, and we don't operate the frontal bone fracture. If there is frontal bone fracture, it has to be operated by neurosurgeon team. We treat mandibular fracture, condyle fracture, orbital fold fracture, as well as medial wall of the orbit, ZMC fracture. If the supraorbital rim or orbital roof is fractured, it has to be operated by neurosurgery, because orbital roof or supraorbital rim is associated with anterior canal fossa. There is presence of dura mater, arachnoid, pia mater, there is CSF. So these structure has to be taken care by the neurosurgery team. Moving to midface fracture, in 1901, René Lifford described the facial fracture patterns observed in cadaver midface after blunt impacts. Even though it was classified in 1901, it is used not till nowadays because it is simple. Okay. Even though the René Lifford has classified the Lifford into 3 types, he has explained the fracture line. Those fracture line are not present nowadays. In practically, you can't find any Lifford 1, Lifford 2, or Lifford 3 fracture which was described by the René Lifford, which he studied theoretically. The reason is, while he has described the Lifford 1, 2, 3 fracture, he has given blunt trauma, he has applied blunt trauma to the cadaver, and he has seen the fracture line. It was low energy trauma. But nowadays, whenever there is road traffic accident or any mass casualty, any trauma, all of them are high energy trauma. In case of high energy trauma, you can't see the clear-cut Lifford line, because most of the time it is associated with other fracture as well. Even though we study theoretically the clear-cut Lifford 1, Lifford 2, Lifford 3 fracture line, but practically you can't find such clear-cut fracture line in the patients, because all of them are high energy trauma. In case of high energy trauma, there are comminuted fracture, and there is combination of Lifford 1, Lifford 2, Lifford 3, or other fracture. Practically, in 100% of the cases, you will not find any of the clear-cut fracture line given by the René Lifford, though you have to study. In case of midface, there are some buttresses, vertical buttresses and horizontal buttresses. Unlike mandible is a strong bone, but it's not like that in case of maxilla. Maxilla is a thin bone, midface is a thin bone, so you have to be careful while doing any surgery. You can't put plate or screw in any area because all of them are spongy bone. The bone is very thin. If you put plate or screw in the spongy bone, it will not hold the bone. Your surgery will be failed. So you have to identify the buttresses. Basically, there are 3 vertical buttresses as shown with a red line. These are nasomaxillary buttress, or we say it as NM buttress. Next is zygomaticomaxillary buttress, or we also say it as a ZM buttress. The next is pterygomaxillary buttress. It is present posteriorly in the pterygoid plates area. Normally, the function of these buttresses is to transmit the occlusal force or functional force to the superior area in the skull area. The nasomaxillary buttress, this transmits the force to the frontal bone. Again, this zygomaticomaxillary buttress will transmit the force to the superior area as well as pterygomaxillary buttress. Among these 3 buttresses, we use only nasomaxillary buttress and zygomaticomaxillary buttress for fixation. We can't place a plate in the pterygomaxillary buttress area. It is present in the posterior region. So we have to put a plate in the nasomaxillary buttress or zygomaticomaxillary buttress in case of vertical buttresses. In case of horizontal buttresses, as seen in green and blue lines, there are superior buttress, middle buttress, inferior buttress. Superior buttress is present in the supraorbital rim area. The thick bone is present. Then infraorbital rim area and zygomatic arch and horizontal part of hard palate. These structures acts as a horizontal buttresses. The function of buttress is to hold the occlusal or functional force or the impact imparted from any external object. It will transmit these forces to the other area. So the forces will be, energy will be distributed and the chances of trauma or injury will be decreased. While treating the midface fracture, we have to put all the plates in this buttress area. The significance in fracture is you must know the buttress area present in the midface, and we have to always place those plate and screw in this buttress area. In case of maxilla, we normally use 1.5 mm system, 1.5 mm plate and screw. Unlike mandible, where we use reconstruction plate or 2 mm plate, reconstruction plate is never used in mid-face. Reconstruction plate is only used in case of mandible. Because the bone is very thin, you can never find any bicortical bone in maxilla. So reconstruction plate is not used in case of maxilla. Well, usually we use 1.5 mm system. Other differences in case of maxilla or mid-face, we have to place at least 2 screws on either side of the fracture line, unlike in mandible, where we have to place at least 3 screws on either side of the fracture line. In maxilla or mid-face, we have to put only 2 screws on either side of the fracture line. Other difference is length of the screws. In case of mandible, sometimes we have, in case of monocortical screw, we use 2 by 6 mm or 2 by 8 mm screw. The length is only 6 mm or 8 mm in case of monocortical screw, in case of mandible. If it is bicortical screw, the minimum length is 10 mm, 12 mm or 14 mm, so that it can hold both the buccal cortical plate and lingual cortical plate. Most of the time we use 12 mm screw. But in case of maxilla or mid-face, we never use such bicortical screw, and the size or length of the screw is, in most of the time, it is 6 mm. Sometimes in infravital rim area, we use only 4 mm length screw, 1.2 by 4 mm. In case of nasomaxillary buttress or zygomatic maxillary buttress, we use 1.5 by 6 mm screw L and 1.5 mm plate. It is thin plate. In 2 screws should be placed on either side of the fracture line. And most of the time we use L plate, L separate, because you can't put a straight plate. If you put a straight plate in the nasomaxillary area or zygomatic maxillary area, it will lead to the dental segment and it may damage the tooth bud, or you may hit the root of the tooth. So you have to use L plate, L separate plate, not a straight plate. Another thing you must remember in case of mid-face fracture is, in case of orbital floor fracture, in all the fracture, what we do, we reduce the fracture and we do fixation with plate and screw. But in case of orbital floor, it is a thin bone. We can't reduce and fix the orbital floor. It is very thin, paper thin bone. So what we do, orbital floor reconstruction, not reduction and fixation. We say it as a orbital floor reconstruction. We have to put orbital mesh made of titanium. Another thing in case of orbit is, though orbit is pyramidal in shape, it has 4 walls, inferior wall, superior wall, medial wall, and lateral wall anteriorly. But if you see the anatomy, it is pyramidal in shape. Once you go posteriorly, there are only 3 walls, because the inferior wall and lateral wall gets fused together. So posteriorly, there are only 3 walls: superior wall, medial wall, and inferior wall and lateral wall fused together. So posteriorly, there are only 3 surfaces, but in anterior area, there are 4 surfaces. It is pyramidal in shape if you see the orbit. And you must remember that the thinnest bone or present in the orbit is orbital floor and medial wall. That's why whenever there is trauma in the orbital area, most commonly you will get the fracture. The fractured area is either orbital floor or medial wall. Orbital floor or medial wall gets fractured in case of trauma to the orbit, because these bones are paper thin bone. As compared to other walls like superior wall, lateral wall, orbital floor and medial wall consist of paper thin bone. So most of the time, whenever there is blunt trauma, it will fracture the orbital floor and medial wall. Once the orbital floor is fractured, you can't reduce this paper thin bone and fix it. You have to do orbital floor reconstruction. You have to place the orbital mesh just below the eye globe. Leaford bone fracture. Leaford bone fracture is also known as Guerin fracture. This term has been asked many times. What is Guerin fracture? It is also known as Leaford bone fracture. It is located transversely above the dental apices and disjoining the alveolar process, the hard palate, and the pterygoid processes. Okay. Also in figure, it is Leaford bone fracture. So the Leaford bone fracture starts at the inferolateral margin of the anterior nasal aperture. The fracture line starts at the inferolateral margin of the anterior nasal aperture, passes posteriorly above the dental apices. It passes still posteriorly below the zygomatic buttress, crosses the pterygomaxillary fissure, and fractures the pterygoid plate at the junction of upper tooth rod and lower 1/3. It also fractures the lateral nasal wall as well as nasal septum. So there will be complete separation of the maxilla with the other part of the midface. You must remember the fracture line. The fracture line starts at the inferolateral margin of the anterior nasal aperture. Fracture line starts at the inferolateral margin of the anterior nasal aperture, passes posteriorly below the zygomatic buttress. It crosses the pterygomaxillary fissure. Pterygomaxillary fissure is just the area which is present between the pterygoid plate and the posterior surface of the maxilla. So it crosses the pterygomaxillary fissure, fractures the pterygoid plate at the junction of upper 2/3 and lower 1/3. The pterygoid plate also has its significance. In case of Lee-Ford fracture, the pterygoid plate fractures at the junction of upper 2/3 and lower 1/3. In case of Lee-Ford fracture, the pterygoid plates get fractured at the junction of upper half and lower half. In case of Lee-Ford fracture, the pterygoid plates fracture at the junction of upper 1/3 and lower 2/3. So whenever there is Lee-Ford fracture, we have to do fixation. We have to put the plate at the nasomaxillary buttress and zygomatic maxillary buttress. You can't put plate at any other area because you don't get sufficient bone. All the bones are spongy, and inside there is big maxillary sinus. Clinically, if you see the Lee-Ford fracture, you will see the whole of the maxilla is mobile. It is floating. Occlusion will be deranged. There will be bleeding intraorally. There will be profuse swelling in the face. Another thing is the Lee-Ford fracture combined with a sagittal palatal fracture, the maxilla is split longitudinally close to the midline. Practically, in a clinical scenario, what we see the most of the time, the Lee-Ford fracture is always associated with palatal split as well. So whenever there is Lee-Ford fracture, we have to see whether the palatal split is present or not. So mid-palatal split is present, and this mid-palatal split is either present on the left side or right side. Most of the time, the mid-palatal split will not take place from the central line. The fracture is not present between the two central incisors. Okay, most of the time it is present adjacent to that area because in the midline there is presence of nasal septum, there is presence of thick bone. So the nature of fracture is that the fracture will takes place only in that area where the bone is thin. The fracture line will always pass from the thin area, the weak area. It is always passed through the area of least resistance. Like in case of thrombogenic infection always spread through the area of least resistance. Similar thing happens in the fracture also. It will fracture the area where there is least resistance, where the bone is thin. So in case of mid-palatal split, the fracture line is present adjacent to the mid-palatal suture. It will not separate the mid-palatal suture. And Lee-Ford fracture is commonly associated with mid-palatal split. Once the mid-palatal split is present, whole of the maxilla is gone. You can't find any occlusion in that area. And it's very difficult to treat surgically as well. Now this is the plane radiograph. X-ray Waters view is shown in first figure in case of Lee-Ford fracture. The Waters view is preferred to view the maxillary sinuses or paranasal sinuses. It is also asked once. What is the indication for Waters view? Waters view is preferred to visualize the paranasal sinuses or maxillary sinus. Waters view is also known as OMV, occipitomental view. Occipitomental view is also known as Waters view. It is used to visualize the maxillary sinus area or paranasal sinuses. In case of fracture, if you see the Waters view, it's very difficult to distinguish mid-face fracture because there are most of the time in case of mid-face there are comminuted fracture, very small pieces of fracture fragments are present, so it is very difficult to distinguish in plain radiograph. So you have to go for CT scan. You have to do the NCCT and you have to visualize all the fracture fragments, all the section, coronal section, sagittal section, axial section, and VRT image as well. Second figure is coronal section. As you can see, Lee-Fort-1 fracture is present. You can see the discontinuity defect present in this area. It is due to Lee-Fort-1 fracture. You can also see the fracture fragment is present in the right ZM buttress region. The fracture line is present in this area. In this area, there is comminuted fracture. Also, you can see the discontinuity defect here. So the fracture line is present in 3 areas. Okay, it is comminuted fracture. Along with Lee-Fort-1 fracture, you can see the discontinuity defect is present. Is also present in the mid-palatal region. Mid-palatal split is also there. Also, you can see the medial wall of orbit is also fractured. The orbital content is extruded towards the midline. Always you have to compare both the side. If you compare the left side and right side, you can see the radiolucency is present here. It is the area which is filled with air appears as a radiolucent, black, and the area where there is blood or any soft tissue, it can be opaque. Comparatively, if you see, you can see the radiolucency present in the left maxillary sinus as well as on the medial side of the left orbit. If you compare to the right side, you can see the maxillary sinus is obliterated. There is comminuted fracture in the zygomatic buttress area. The orbital content of the right orbit is extruded to the medial surface. Now, in this condition, you have to address medial wall fracture as well as ZM buttress, as well as Lee-Fort-1 fracture, as well as mid-palatal split. So in mid-face, you can find if there is, you'll find in case of road traffic accident or severe trauma, there is comminuted fracture and many bones are fractured simultaneously. You can't find isolated classical Lee-Fort-1 fracture or classical Lee-Fort-2 fracture. It is associated with other bone as well. It may be associated with Lee-Fort-1, Lee-Fort-2, Lee-Fort-3, all together along with Inouye fracture, along with orbital fracture, along with ZMC fracture. So there is combination of fracture. This is the VRT image or 3D image of mid-face fracture. You can see the occlusion is complete, open wide in the anterior area. Mid-palatal split is also there. Fracture is present in the Lee-Fort-1 area. ZM buttress is also fractured. You can also see the fracture in the infraorbital rim area. Similarly, in the right side also, infraorbital rim is fractured. Nasal bone is also fractured. There is frontonasal disjunction as well as frontal process of maxilla is fractured. The junction present between the frontal bone and the frontal process of the maxilla is also fractured. Also on the right side, you can see the zygomatic bone is fractured. ZM buttress is gone. This is clinical picture of one of our patients. So in such cases, you have to first. Another thing, have you heard the term of panfacial fracture? What is panfacial fracture? Panfacial fracture भनेको के हो? सुन्नु भएको छ पहिला?
mandible, maxilla, zygomatic bone, nasal bone सबै पर्छ हैन सर फेसको.
So in exam also you will get the question from the panfacial fracture. What is panfacial fracture? So if you divide the face into 3 parts, lower face, middle face, and upper face. Below the mandible is considered as lower face. The mid face below the frontonasal suture is considered as mid face, and the frontal bone is also considered as upper face. So if you divide the face into 3 parts, lower face, middle face, and upper face. Upper third, middle third, and lower third. Lower third is mandible. Okay. Middle third is mid face. Upper third is the frontal bone. If you divide the face into 3 third, upper third, middle third, and lower third. Among these 3, if any 2 of the part is fractured, and one of them must be mid face. If the mid face is associated with mandibular fracture, then it is considered. Then it is called as panfacial fracture. If you divide the face into 3 part, lower 1/3, middle 1/3, and upper 1/3, Among these three, if any of the two parts is fractured along with the midface, then it is considered as panfacial fracture. So panfacial, in case of panfacial fracture along with midface, either frontal bone is fractured or mandible is fractured, or both of them may be fractured, then it is considered as panfacial fracture. So in order to define the panfacial fracture, you have to divide the face into 3/3, lower 1/3, middle 1/3, and upper 1/3. Among these three, if the midface fracture is associated with either mandible fracture or frontal bone fracture, then it is called as panfacial fracture. Okay. So in panfacial fracture, it is very complex. You have to operate these cases accordingly. There are the various guidelines. You have to address the mid-palatal split, leaf 1 fracture, leaf 2 fracture, leaf 3 fracture. Surgical approaches for leaf 1 fracture or midface fracture. In most of the time, in case of midface fracture, we don't give extraoral incision, because if you give the extraoral incision, the scar mark will appear. That is, there is problem with appearance. So you have to consider that one also. Never give incision from directly over the face. Always you have to give the incision from the transoral approach. Vestibular incision is preferred in case of midface fracture. Through the transoral incision, vestibular incision, you can expose the NM buttress, ZM buttress, as well as sometimes the infraorbital rim, and you have to reduce the fracture fragment, and you have to do fixation with mini plate and screw. Reconstruction plate is not used in case of midface fracture. So aesthetic is a major problem in case of midface fracture. For aesthetic reason, never give incision in directly over the skin in the midface. If sometimes what happens, already there is a scar mark, already if there is laceration, if the lacerated wound is already present, if the previous scar marks are present, then you can give the incision through the skin. Otherwise, for aesthetic reason, never give incision through the skin in the midface area. You have to always go through the transoral approach or intraoral approach. So the most commonly the preferred incision is vestibular incision. Vestibular incision is given about 4 to 6 mm above the mucogingival junction, and the mucoperiosteal flap is raised. Once the mucoperiosteal flap is raised, you have to explore the nasomaxillary buttress. You have to address the zygomatic maxillary buttress. If the fractures are present, first you have to reduce the fracture fragment. You have to do IMF. Intermaxillary fixation should be done because the function is most important. You have to bring all the tooth in the occlusion. Once the occlusion is established, then you have to fix the fracture fragments. Now the problem with leaf 1 fracture is most of the time it is impacted fracture. The fracture is present at the leaf 1 level, and the whole of the maxilla may be impacted to the midface. So in such cases, first we have to disimpact the maxilla. For disimpaction, Rose disimpaction forceps is used. It has been asked in the exam, what is Rose disimpaction forceps? Why it is used? Rose disimpaction forceps is used to disimpact the maxilla. The name itself suggests it is disimpaction forceps. It is present in pair. It is different for left side and right side. One of the beak is inserted to the nasal cavity, another beak is inserted into the oral cavity, and you have to apply the force occlusally downwards simultaneously, and you have to disimpact the maxilla. Once the maxilla is disimpacted, then you have to reduce to the pre-injury state and you have to fix it. The Rose disimpaction forceps is used to disimpact the impacted maxilla in case of leaf 4 fracture or leaf 1 fracture. It is also very technique sensitive because you are holding the two Rose disimpaction forceps simultaneously, but the direction of force should be same. You have to apply the downward force or occlusal force simultaneously, because if you don't apply the equal force on both the forceps, the problem is there will be mid-palatal split. You will split the mid-palate. You will fracture the maxilla. So be careful. While holding both the forceps, you have to apply equal force, and you have to the direction of force should be equal, and in the it should be in the magnitude and direction should be same. If there is some disturbance or discrepancy in the direction or magnitude of force, there may be chances of mid-palatal split. You will split the maxilla into two parts. there will be iatrogenic injury. So be careful. Another forceps is Houghton-Williams forceps. It is also used to disimpact the maxilla. It is also used to mobilize the maxilla. It holds whole of the maxilla simultaneously. Then you can reduce it. The fracture maxilla can be reduced with the help of Houghton-Williams forceps. Now you can see in case of lymphotomal fracture, you have to stabilize the maxilla with the help of L plate. Unlike in mandible, you can't use the straight plate because in this case, if you use the straight plate will enter into the dental area and it will damage either tooth pod or the screw will enter into the root area. So always in case of midface fracture, you have to use L separate plate. Okay, one plate is used in nasomaxillary buttress area, another plate is used in zygomatic maxillary buttress area. Bilateral two plates are used. This is the clinical case we have operated. There was comminuted midface fracture. You can see the fracture defect is still present. This is maxillary sinus area. This is the maxillary sinus. Whole of the maxillary sinus is open because the bone which is present on the anterolateral surface of the maxillary sinus is paper thin bone. In case of major trauma, and when there is comminuted fracture, whole of the interior wall of the maxillary sinus will be fractured, and you can't reduce those paper thin bone with the help of plate and screw. In such cases, you have to just put the plate in the nasomaxillary buttress area and zygomatic maxillary buttress area. At least 2 screws should be placed on either side of the fracture line. So one plate is placed at the NM buttress, another plate at the ZM buttress, and it is reduced. So before reducing the fracture line, or before fixation, you have to put the occlusion in the intermaxillary fixation. First, you have to do the intermaxillary fixation. You have to get the occlusion. Once the occlusion is fine, you have done the intermaxillary fixation. Then you proceed with fixation. In case of G41 fracture or G41 surgery, it's the same. But the difference is in case of G41 osteotomy, such defects are not present. There is clear cut fracture line. Osteotomy cut line is clear. Okay, we'll continue upper mutation next class. बुझिएको छ कि छैन? फ्र्याक्चर भयो कसरी म्यानेज गर्ने के देखिन्छ थाहा